All right. Shit. Gotta stop smoking. What we're going to cover first actually directly relates to what we just finished in the last lecture. So lymphatic system, remember, is that system that picks up your excess fluid from capillary, because remember we have a net movement of fluid out of the capillaries, and that 10% is picked up again by the lymphatics and put back into the circulatory system at either the left or the right subclavian vein. All right, so this is just a schematic of what that looks like and how it parallels the cardiovascular system. You will find, and we'll talk about all this, lymphatic capillaries in between all of the regular circulatory capillaries. That's where they need to be to pick up that excess tissue fluid. One of the major differences, though, you'll find along the way once you get to bigger and bigger lymphatic vessels is you'll have these guys along the way, lymph nodes. All right? And lymph nodes are going to serve a very important purpose for filtering this fluid that's being returned back to the circulatory system. Because do you want to return dirty fluid back to a circulatory system? No. So we have to have a way to clean that out. So not only does the lymphatic system return excess tissue fluid, but it cleans that fluid as well, so to speak. All right, like I said, lymphatic capillaries, microscopic level, are embedded within a capillary, a circulatory capillary bed, all right, to help pick up excess fluid. Another major difference, if you can see right there, it's a one-way path. All right, you pick up excess fluid, you transport it back into the circulatory system. There's no arterial, capillary, venule, then back. It's just a one-way capillary system that gets bigger and bigger until it gets back to the dumping into venous circulation. Okay, but the walls, just like regular capillaries, are made up of endothelial cells. So very similar structure in terms of cellular level of organization. Okay, so any fluid that is in the lymphatic vessels, I just thought of something. I don't know what kind of conception you have about the circulatory system or the lymphatic system, but they're always filled with fluid. There's never a time where they're not actually, where there's like bubbles in there or empty space. They're always going to be filled with fluid. Just consider that. All right, so lymph formation. Lymph is just the fluid that's entered into the lymphatic vessels. So in the interstitial space, it's interstitial fluid. In the lymph, it's lymph fluid, but it's the same stuff. Okay, so here, very similar to plasma. Remember what plasma is? Blood without the cells. Okay, so very similar to plasma. But instead of plasma proteins, you have tissue proteins from the interstitial space. Okay? Here would be interstitial cells, all of these bigger ones right here. These little squamous epithelial cells, endothelial cells, are making up the capillary, lymphatic capillary. Right? And you notice between each one of these endothelial cells, there is kind of a valve, a pore. All right? Actually, it's a pore, but it acts as a valve. Because when interstitial pressure, because remember, anything that has fluid is going to have pressure. Remember the balloon example? If we fill up a balloon with water and pop it, it's going to burst because it's under pressure. Interstitial fluid is under pressure. So when that pressure increases, meaning there's more fluid in the interstitial space. That's going to open these valves and push fluid into the lymphatic capillary. All right, but we're talking about very small pressures and very small pressure differences. So it's not like you're going rushing a bunch of fluid in there. It's just enough pressure to open those valves and get fluid moving into the lymphatic capillary. All right, really quick, lymphatic vessels, when they get bigger, so you go from capillary to bigger lymphatic vessels, have the exact same structure as veins. All right, they're going to have the exact same structure as veins. So if you can't do this in the anatomy table. I guess you could. If I were to put up just a body and circulatory lymphatics with no coloring in it, how would you tell a lymphatic vessel from a vein? No coloring. They're not green. In fact, they're going to look just like veins. So how would you tell the difference? Possibly location, but remember, lymphatic vessels are going to they're going to run parallel to venous circulation. So that may not tell you what you need. You're missing something. Nodes. They're going to have lymph nodes along the way. So if you are traveling up and you see, oh shit, what's this ball? Probably a lymphatic vessel. All right. They also contain valves, just like veins, because they're under very low pressure, so they have to have a way to prevent backflow. All right, we already talked about lymph function in terms of the digestive system. Remember, each one of those villi have these capillaries and then lacteals in there that are designed to absorb fat specifically. We already talked about that, so we're not going to go into there. But the main function of lymph, by and large, is to prevent fluid accumulation. Remember, your circulatory system dumps more out at capillary level than comes back in. So these pick up that extra tissue fluid. And if you don't have if you don't have lymphatic vessels, fluid accumulates. And those pictures right there show you a few examples of fluid accumulation as a result of lymphatic dysfunction. Okay, the first would be, could be infection, blocking lymphatic vessels. Could be maybe they had a surgery in the inguinal area, taking out lymph nodes. When you take out lymph nodes, you take out lymphatic vessels. When you take out lymphatic vessels, you prevent drainage of your leg. That could happen. This guy, I'm not sure what happened. I just thought it was kind of a funny picture. It shows edema, and it can occur everywhere. In fact, it was weird. This weekend, I'm doing the nursing thing tomorrow. I'm doing a nursing thing on Monday. So if you guys need anything, I will not be answering emails those days. Okay, but I did nursing thing this past Saturday too. One of my patients, she comes up to me in the morning. I just got there for my shift, and she's got a rag over her mouth, or her hand over her mouth, or no, she had literature over her mouth, like a book or something. She's like, "I'm sorry, can I have a rag or something?" And she showed me her lips, and her like, she just got them pierced before she came into the hospital, and like they were super swollen. Inflammation. More fluid to the area than what you can drain. That's probably what's happening to this guy. He probably got punched in the face or ate something he shouldn't have. Does anybody know what's going on here? Bad? Did you say bad? Very bad. Very, very bad. Anybody know what that's called? I want to hear it. I want to hear it because I want to correct you. Nobody knows what that's called? What?
Is it right on the board and try to say it?
No. All right. Usually people say this is elephantitis, which would be inflammation of your elephant. Right? It's elephantiasis. All right. What these? I just think it's funny. Anybody know what causes that in third world countries? Parasites. They get into the lymphatic system, take up residence, start reproducing, block your lymphatics. No drainage. And you develop these really gross, not gross as in disgusting, but gross as in large and obvious, edemas. All right? They go on for a long period of time, and that's why they look the way they do. Bad. That's all fluid. Bad juju. Over time, that can cause tissue changes as well, which is why you see like drying out of skin and why you see like these rough patches and other growths as well. But it all started with a lymphatic blockage from a parasite, parasitic worms generally. That's a good question. I don't know the answer to that. It can happen in both, but they just took up residence there. Maybe over time they'll develop another one. It happens. I don't know the answer to that. Is epidemiology an open career path for you guys as PAs? Do you know? Probably not. It'd be interesting, I think, like to study these kind of things, and it would answer your question. I've got some friends that are epidemiologists. I don't think I'd want to do their work. I mean, they're working like, really? Do you want to work in a sandfly population and run the risk of getting bitten? No. All right. So, lymphatic function, or lymph function. So we know what lymph fluid is now. We know that it transports stuff. In that fluid, we return it to the bloodstream. But before it goes to the bloodstream, it passes through these lymph nodes along the way. And again, we tell the difference between a vein and a lymphatic vessel because they have lymphatic vessels have lymph nodes along the way. All right. The way this works is that you have a bunch of lymphatic vessels feeding in. What does this lymph node kind of look like? A kidney. All right. So you'd have it flowing into what would be like the cortex of the kidney. That's not what that's called. And then it goes through and then out the hilum of the lymph node. All right, so the spot where lymph exits is called the hilum. The spot where it enters is in the opposite side of the hilum. I'm sure it has a name. I'm just not bringing it into existence at this moment. All right, lymph nodes are made up of reticular connective tissue. All right, and reticular connective tissue is all collagen, but it has this net-like appearance. So in essence, what you create inside of your lymph node is a 3D maze for fluid to go through. And in that maze, just like Greek mythology, you have monsters called macrophages. All right, and anything that is traversing with that fluid through that maze will come in contact with the macrophage, will come in contact with one of these monsters, and get eaten. Okay? So that's the way that your lymph nodes will filter out harmful substances from the fluid returning to circulation. All right, so when it says lymph transports foreign particles to lymph nodes, those foreign particles are what's getting eaten by those macrophages. You guys thought the humanities would never come in handy. All right. Lymph movement, remember, very low pressure, so it's going to move the same way fluid's going to move the same way veins do. Skeletal muscle contraction, the more I move around, the more I'm, pushing fluid through my lymph system. Breathing, is breathing in or breathing out the mechanism to bring more fluid into our thoracic cavity? Breathing in. Low pressure, gets pushed up. All right, so that's our respiratory pump and our skeletal muscle pump. All right, and of course, veins prevent backflow. If we interfere with lymph flow, we talked about the consequences of that, and we showed some pictures, right? The other thing is lymph movement, lymph flow can also transport cancer cells, because cancer cells can be within the interstitial fluid, get into the lymph capillary, and travel through lymphatic fluid. All right, so that's one mechanism where metastasis can occur. All right, so how do we think about lymphatic pathways? Here's your flow diagram. Lymphatic capillary, afferent lymphatic vessel to lymph node, afferent going toward a lymph node, efferent going away from a lymph node. And then you have probably several along the way to a lymphatic trunk. Remember our thoracic duct, cisterna chyli, to a collecting duct, to a subclavian vein. All right. If you are draining area 1 of your body, which is everything but the right upper extremity, right upper half of the body, extremity, yeah, goes to the thoracic duct. The right arm, right chest, notice not the right abdomen, so it ends at the chest, and head and neck go into the right lymphatic duct. All right, and I think there's a nice picture similar to that in your bare bones book that show lymphatic drainage. All right, one of the reasons why I included this picture right here of females in particular, lots of times you will see women who have undergone a mastectomy because of cancer wear this cuff on their arm. Right arm. Wear this cuff on their arm. Why are they wearing that cuff? Because what? Edema. Because in taking out the breast, you took out a lot of lymph nodes too. Therefore, lymphatic vessels. So fluid's going to accumulate in the arm, and they have to wear this pressure cuff to keep fluid moving. What ribs are breast tissue located on? Yes. I did, and well, answer me this. When you guys were taking that test yesterday, I saw almost everybody counting ribs. Were you counting ribs to see whether it was false or true, or were you counting ribs to see where breast might be? Both?
It's the same exact principle of using the calculator on that test for 4.7. I know it. I want to confirm it.
Right. So I enjoy the psychology of exam taking and watching you guys do certain things. It's fun to me. What else did I see? I looked in the lab and I saw somebody going. All right. I guess this is the picture I wanted to show you. your afferent side versus your efferent side. The hilum is on your efferent side of a lymph node. Okay, and we showed a picture of that earlier, so I'm not going to go into a whole lot of detail about that. We talked about the reticular connect. I got ahead of myself. And the macrophages in there eat anything foreign that gets in there. But you also have lymphocytes in there. All right, and that's important because lymphocytes are your adaptive immune system. They are what make you immune to certain diseases. That's why you get a cold and you never get that exact same cold again. All right? So why do you have both in here? Macrophages will eat, and we'll talk about this process, the foreign particle, display it on its surface, and then present it to your lymphocytes. And your lymphocytes will say, all right, I either need to produce killer T cells to kill whatever's in here, or I need to produce B cells that will secrete antibodies. All right, so all the magic happens in these lymph nodes. Okay, we just talked about this. So if lymph node function, if you want to make a bullet list, filter harmful substances. We talked about that. And immune surveillance. All right, that means it's looking for anything that is not you. All right, so that takes us into some more lymphatic organs. One will be the thymus. The thymus function, God, when I was looking over this lecture again to give it to you guys, I'm like, oh my God, I'm curious about how the thymus works. Like, I wanted to dig deeper. I didn't have time to do it, so I didn't. So I don't have the answers I want to give you. But thymus function is similar to a lymph node. So fluid goes in, surveys things, takes care of them, fluid comes out. All right. Typically, it's located on the superior border of the heart, on top of the great vessels. And in children, it's huge, relatively speaking. In adults, it shrinks because one of the functions of the thymus is to run an inventory of every protein on every cell of your body and kill any lymphocytes that may react to them. Okay? So it takes an inventory of all the proteins on every cell of your body, based on what's flowing through there, and kills lymphocytes that will react to them because you don't want an immune response against your own tissues, right? So the thymus ensures that that doesn't happen. So, how do we get autoimmune diseases? There's theories out there. Does anybody know what the most current popular theory is? And actually the most widely accepted theory? Give you a hint. It's along the same vein of why we have anti-A and anti-B antibodies. No? You're exposed to some kind of pathogen that has a very similar antigenic properties as one of your own proteins. So then it cross-reacts to your own proteins, and now your own immune system, because it's trying to take care of this pathogen, attacks your own tissues. All right, spleen. Another lymphatic organ. You guys know where that's located. And Victor has a huge spleen, right? Was it Victor? Or Victoria does too, doesn't she? Or is hers? I don't remember. Victor's is gigantic. It looks like another liver. All right. That's considered our largest lymphatic organ. We know where it's located, and it has two areas within it. White pulp, which has functions and structure very similar to that of lymph nodes, which means it's going to survey fluids. And then it has red pulp that contains red blood cells and a bunch of lymphatic white blood cells that will remove damaged red blood cells from its circulation. What's another name for damaged red blood cells? It's that long S word. That means you're getting old. Rhymes with pubescent. Senescent. Senescent. I never heard that word. I said it. Okay, malt. Malt. Mucosa-associated lymphatic tissue. Mucosa-associated lymphatic tissue. So these are those small patches of lymphatic tissue that are scattered in certain places of our body where we have openings for foreign invaders that will take care of them before they get in, or at least alert our body that, all right, they're taking in something that they shouldn't be taking in. Let's mount an immune response. All right, so you'll see them in the GI tract. One of them, the Kupffer cells, remember where those are located? Liver, right? So those are located in the liver. They help monitor blood flowing through the liver. Your tonsils and adenoids in your pharynx, they will monitor things that you're eating, right, and alert the immune system if something bad is coming through. There's some in these other places as well, all right? So malt, mucosa-associated lymphatic tissue, small patches in certain key areas that will help aid in the monitoring of things running past it. All right? They contain the same things that lymph nodes have, that the spleen has, that the thymus has, all geared towards that immune surveillance function. All right, we're done with lymphatics. Really? I'm not making fun of you. I'm just... body defenses. So now we're getting into the immune system, how the immune system works. So the whole goal of our let's not even say immune system at this point. Our body has a defense system, all right, that tries to prevent anything that's going to harm our body from getting in and harming our body, all right? And we have different lines of defense, all right? Our first line would be like mechanical barriers. Skin is the best one, right? That keeps things out that shouldn't be there. When we cut, we get infections because we just open that barrier, all right? So that's a really good mucous membranes. Also, remember mucous membranes have mucus. They trap, have cilia, move things along. You can spit out, swallow them, things like that. If you get past this first line of defense and a pathogen actually gets into the body, first we have our second line of defense, and that is our either called innate, which means it's going to be there and it's going to defend no matter what, or non-specific defenses. So this is like your... like your motion sensing gun that will just shoot anything that comes in, right? No matter what. So these are like like the stomach acid, for example. When we swallow things, they don't infect us because that stomach acid just kind of kills them. We have lysozymes in our tears, which kill foreign invaders. Natural killer cells. Inflammation, the inflammatory process, phagocytosis, macrophages, neutrophils, things like that. Those are our non-specific lines of defense. They're going to kill indiscriminately if you're foreign. And then we have our third line of defense, which is if you get past all this, we're going to fuck you up. Okay? That's our immune response. So the third line of defense, the last line of defense, and the most effective is the immune response. And that has two branches, your cellular and your humoral, and we'll discuss what those mean. All right, just some explanation of nonspecific defenses. I already talked about mechanical barriers. Natural killer cells, they are kind of a distant cousin of the T cells and B cells. And basically what they do is when they contact something foreign, they just kill them. They don't eat them, but they'll kill them. They'll like poke holes in them and the cell deflates, things like that. We talked about chemical barriers. There's just some more examples there. Fever is another defense mechanism. You as providers really need to recognize that the fever response is an important response that has to happen. Okay? So don't always be so quick to say, all right, we're going to give you something to reduce your fever. You got to look at the whole situation and determine why or how long that fever has been going on and if it's going to cause problems. All right? So it is a normal process that's designed to kill things that get inside. All right? What fever does, everybody thinks that fever, the high temperatures kill microbes. It's not the high temperature that's actually killing microbes. What the high temperature does is it makes the liver and spleen take the available iron, put it into a storage form so bacteria can't get at it. And if bacteria can't get at it, they need iron to be able to survive and reproduce. So it sequesters that iron and makes it unavailable for bacteria. And here's how it works. All right. So we get an infection. For example, our body releases chemicals, what we call pyrogens, and that's like interleukin-1 or tumor necrosis factor. Right? What that does is it goes to our hypothalamus and says, hey, we need to take that temperature and raise it a few degrees, all right? Because we got something foreign invading. Let's raise the temperature to get rid of it. So what happens is the hypothalamus will raise that temperature, and it will tell our body to do things to raise the temperature. And what kind of things do we do to raise our temperature? We shiver, right? So we don't shiver because we're cold. We're cold because we're shivering. Okay? We don't shiver because we're cold when we have a fever. We're cold because we're shivering. That shivering response raises our body temperature higher than the environment, so we're feeling cold as a result. Does that make sense? Okay. We vasoconstrict. All right, so we turn pale a lot of times because that blood goes to our core, raising the temperature really quick. We increase our basal metabolic rate. We increase our heart rate. We curl up our body into a small position because we feel like shit. But that also makes us raise the temperature really quickly. All right? Temperature goes up. We kill whatever's going on. The hypothalamus is reset, and it comes back down to normal temperature. All right? At some point, if it goes on too long or if it's too high, we want to give pyrogens or treatment to remove the pyrogens. So that's when we give our acetaminophen. You guys, I don't know if you've gotten to this in pharmacology. Tylenol or Motrin to reduce a fever? Which one? Tylenol. Motrin doesn't touch it. Motrin works on pain and inflammation, but not on fever. Okay? So you want to give that, again, if it's gone on too long, if it's severely affecting quality of life, or if it's too high. Again, what's the, I'll give you a hint. Similar to acid-base, why don't you want your temperature to be too high? Denatures proteins, right? Mess you up. All right, inflammation is another non-specific defense characterized by warmth, redness, swelling, and pain. All right, the four hallmarks Sometimes there's a fifth called loss of function. But the four main characteristics of inflammation, redness, swelling, warmth, and pain. All right. Why does this happen? Let's do this. Pictures. All right. We get an injury. All right. What happens, one, is the smooth muscle surrounding the blood vessels going to that injury will dilate. All right. When smooth muscle around blood vessels dilate, what happens to the amount of blood going to an area? It increases. Right? So you have an increase in blood going to that area. All right. If we have an increase of blood going to the area, actually, capillaries also. Remember, capillaries have these slits in them, these pores. Inflammation will actually widen them. So they'll tell the cells to kind of shrink up a little bit, widening those pores so that more stuff can get out. So now you have more blood going to the area, higher pressure, more fluid able to go out. So not just water and stuff that's dissolved in water goes out, but cells are starting to go out. All right. So if you have fluid coming out more than your lymphatics can pick up and return, what's that going to create? Pardon? What part of inflammation? Remember the four key hallmarks. Swelling. That'll create the swelling or edema. If you have red blood cells going out to that area, what part of inflammation is that going to create? The redness. That's why you get the redness. Why do you have the warmth? More blood going to this area and the blood is warm. All right? Especially if we're talking about skin. In pain, why do we have pain? There's two reasons. Guesses? Swelling will, cause pressure in the area. It won't squeeze the vessels, but it will squeeze pain receptors, right, and activate pain receptors. And also, damaged tissue in this area will release chemical mediators that will also trigger pain receptors. All right. Why do you want pain during inflammation? You have to have it. It's important. Why? Pardon?
So you know it's there.
So you know it's there, and you limit your movement, right? You limit your. You don't do things that will damage it further, right, and cause more inflammation. Good. All right. You also have, at the area of inflammation, a lot of clotting proteins being released. All right. So effectively, what you do around an area of inflammation, and it's not this simple, but you create like a bubble, that keeps everything in here that's going to cause a problem, and make sure that all these white blood cells that are getting out and all these macrophages that are attacking clear that area so they don't go anywhere else. All right, so if we go back a slide, coagulation of interstitial fluids. The coagulation of interstitial fluids prevents things from moving beyond the area of inflammation. Does it always work? No. There are cases where it doesn't. But that's the goal of doing that. All right? You're also going to release a lot of chemical mediators that are going to attract more neutrophils and more monocytes to become macrophages to get to the area and eat things. All right? And that will help moderate that inflammatory response. Some of the chemicals involved are listed down here. Some of them already have vasodilator properties. Histamines, serotonin, prostaglandins, all have vasodilator properties, but they also take part in these other things involved in inflammation as well. So inflammation, very important process to kill whatever's, or eliminate, rather, whatever is getting into your body to cause problems. Another thing with inflammation, it's an important thing. don't be so quick to treat an inflammation in your patient if it's going to help get rid of whatever's causing a foreign problem. Look at the whole picture before you decide to make that decision. If it's going on for too long, yes. If it's affecting quality of life to where they can't function, yes, give anti-inflammatories. Crohn's disease causes a lot of inflammation. That can cause problems. You want to treat that, right? Okay. That just talks about what we already talked about. As far as the white blood cells' role in inflammation, you already have, let's call this a capillary. This is our tissue. You already have macrophages in the tissues that are there ready to, they're kind of crawl, they crawl around. It's really weird. Like when you think of sperm in your body and when you think of macrophages in your body, there's these little things crawling around. It's kind of gross. It's like bugs crawling around in your body when you really think about it. Anyway, these are crawling around in your body, in the tissue. If something happens, you get poked, you get stabbed with a knife. These macrophages, usually have bacteria on the knife, will immediately go and attack those bacteria, right? They're right there. That's our first line of defense at the tissue level. All right? The macrophages are going to do a couple things. One, they're going to present foreign invaders on their surface to activate an immune response, but they're also going to send out chemicals that will travel in the bloodstream and attract neutrophils and more macrophages to that area. We call that chemotaxis, following a chemical gradient to a site of infection. Okay, chemotaxis, using chemicals to create a gradient to bring more neutrophils and macrophages to the area. All right, these chemicals will also cause changes in the endothelial cells of the blood cell. Endothelial cells of the blood vessel. That will cause white blood cell neutrophils and macrophages to kind of bind to them, slow them down, so that they can get out of the blood and into the tissue. All right. This process of binding to endothelial, that's the word I'm looking for, proteins, slowing down, that's called margination, like you're going along the margin of the blood vessel. And getting out is called, it's not on here, diapedesis and extravasation. Extra, out. Vascular, the process of getting out of the vascular system. Extravasation. Leaving the blood vessel. All right, and diapedesis means cell walking, so it's going to basically walk along, extravasate, and get to foreign invaders. I guess I didn't have to draw the picture. This is just showing you that same thing. So here's our neutrophil. Here's some surface proteins expressed by the endothelial cells. They literally bind, but it's like a temporary binding, just enough to slow down this white blood cell so it can squeeze through. And remember, these these endothelial cells now have bigger pores in them, so it's easier for these guys to squeeze through. So they slow down, squeeze through, get to the foreign particle. I have videos. They're embedded in here, but they are also out in Canvas. If you want to see this process in action, these are really good videos that show how this happens. I recommend watching them to help with your understanding. All right, so when you have inflammation, let's say your patient has inflammation somewhere in their body. You don't know it, though. They're having pain, right? And you're like, all right, I'm going to order a complete blood count and a differential. Okay? If you see an increase in white blood cells, what does that tell you? Infection or inflammation? Does inflammation always have to be tied to an infection? No, because if I punch Nick in the face after he beats my ass, because that will happen, his face is going to get inflamed. It's not an infection, but it's going to get inflamed because he's got damaged tissue. All right, but you're going to see an increase in inflammation. If it's specifically inflammation, you're going to specifically see in your differential an increase in white blood cells. I'm sorry, neutrophils. You're going to see an increase in neutrophils. And that's what we call neutrophilia. All right. White blood cells are going to go to the area. You need to replace the white or the neutrophils that left circulation. So now you're going to be producing a lot more neutrophils. All right. So they're going to be increased way above normal. All right. So this would be normal amounts. This would be inflammation amounts. All right. All this slide is saying is, remember those macrophages that were kind of hanging out in the tissue waiting for a knife? They die. But they've also signaled for more macrophages to come in. So a secondary macrophage invasion will occur after you make new macrophages and they get to the area. All right, because simply because you're producing more of them. That's all this is saying. And it's during this secondary macrophage invasion that we will do the biggest part of presenting antigens to alert the immune response. All right, so where do these macrophages come from? Bone marrow, just like every other cell of the blood. Okay? Remember, we have those hematopoietic stem cells. When they get the signal to create more macrophages are going to be created. Typically, about 3 or 4 days for brand new macrophages to mature and reach into the circulatory system. I know the previous slide said 8 hours, but those are the ones that are being held and being mobilized. Okay, brand new ones are released after about 3 or 4 days. Okay, notice that the bone marrow can increase production of neutrophils and monocytes. Do you guys know the difference between monocytes and macrophages? Monocytes are what get produced by the bone marrow. They're in circulation. When they exit circulation, they become macrophages. They start crawling around. All right? They can increase 20 to 50-fold during times of inflammation and maintain that for months or years. So you have a patient that has a chronic inflammatory condition, have high levels of neutrophils and macrophages for a long period of time, like you're monitoring those to see how well things are going. All right, when you are cleaning up, when your inflammatory process is dying down, it's like a battlefield, right? You have dead bacteria, you have dead neutrophils, you have dead macrophages, dead tissue. All of that makes up what we call pus. Ew. Okay? And often this is inside of a cavity. Why do you have a cavity at a site of inflammation? Dead tissue. You've killed off a lot of tissue in the area. Because one of the consequences of the inflammatory response is not just killing an invader, but it kills surrounding cells as well. Okay? So that's important to keep note of. That's why you have an injury. Again, over a period of time, days to weeks, they say the pus is absorbed into surrounding tissues and the lymph disappears. Fluid's absorbed, new macrophages come in, eat all that stuff up, clean it up. All right, I don't know if you're gonna where you learn this or if you're gonna learn it. Like, there's different kinds of pus too, different types of inflammatory exudate. If you see a green inflammatory exudate, what does that usually mean? Bacterial infection, specifically. All right, so that takes us through all of our second line of defenses. Remember, we have our first line of defense, second line of defense. Now we have our third line adaptive immunity. So that's what the rest of today is going to be talking about, is how does the adaptive immune system work and why it's important. All right. Do you want to take a break now before we get into this, or just start into it and take a break in about 10 minutes? Because I will need a break. Now? Okay. All right, the adaptive immune system. All right, when we think of not getting diseases or being immune to them, this is the process we're thinking of. So there's two things about it. Or three things actually. It says two here. Three things. It's highly specific, so we'll only one immune response, or one adaptive immune response will only recognize one thing and take care of it. It's able to distinguish yourself from anything foreign, and it has a memory. All right, not like a nervous system memory, but we produce cells that will remember what you've been through before. Okay, so let's talk about how it works. First of all, in order for the immune system to work, we have to have these things called antigens. All right, an antigen is simply anything that will trigger an immune response. All right, typically they are carbohydrates or proteins. Typically they are carbohydrates or proteins. Okay, actually that's listed here. Proteins, polysaccharides, that's a carbohydrate. Glycoproteins, it's actually recognizing the sugar here. Or glycolipids, they don't recognize the lipids, they recognize the glyco, the sugar part of the lipid. All right, so that's what they're attacking. That's what they're building a defense against. All right, within see if I can draw this. No, you don't have to know. It sucks. Specific structures of things. But let's say that this is a sugar polymer. All right. Typically, what the immune system will recognize is not the whole thing, but it will recognize a certain part of it. Okay? If it's a protein, and remember proteins are highly folded and they have a very specific structure, it will recognize not the whole protein, but maybe a specific part of it. Okay? Or another part of it. Okay? These are what we call epitopes. All right, so when you talk about different epitopes, we're talking about the part of the antigen that the immune system's actually recognized. And so one of the ways that we can actually develop custom-made antibodies is a lot of the epitopes for things have been mapped. We can just take this part of a protein, inject it into a rabbit or a mouse, and they'll create antibodies against it. We take the antibodies out and we market them and sell them to labs. Okay. So the immune system is all about our lymphocytes, not the other white blood cells, just the lymphocytes. And with lymphocytes, you should always be thinking T or B. All right, their life story starts in the red bone marrow. Just like any other white blood cell. And notice they release them in an undifferentiated state. That means you can't tell the difference between a B cell or a T cell or the different types of T cells. So it's an undifferentiated. Some of these undifferentiated cells will go to the thymus. All right? In the thymus, they'll become T cells. All right, so most of our T cells will come from the thymus. Some are going to kind of hang out in the bone marrow here. And those are going to become B cells. So they'll finish their maturation process in the bone marrow and become B cells. This isn't true. B cell bone. That's not where the B comes from, but that would be a good way to remember it. All right. Once they mature, though, they will leave and they will take residence inside lymph nodes, inside the spleen, inside MALT, mucosa-associated lymphatic tissue. Okay? So that's where they come from. So they all come from the bone marrow. Then they go to different places and take up residence. All right? They're not doing anything at this point. They're waiting to be activated. All right? And when do they become activated? Foreign invaders. It's like you're creating your army, and your army's kind of useless until you have something to fight against. Do not get in an argument with me about the politics of a military. I'm not doing it. So this is just showing you kind of a different view of that, where you have your hematopoietic stem cells, and they can go down one of two pathways. If they go into the thymus, they become T cells. That will help moderate cell-mediated immunity. If they become B cells, they will take residence in lymph nodes, for example, and that will help moderate our humoral branch of the immune system. All right. Cell-mediated immunity makes sense. It's cells that are driving this. Humoral-mediated immunity also has cells driving it, but humoral means in fluids. So we're talking about antibodies that are secreted and dissolved in fluids that will be doing the job. All right, with T cells, they go into the thymus. They mature. All right? When they encounter a single antigen, when one T cell encounters a single antigen, it will then explode into a population. Okay? It'll start rapidly dividing and make one population of T cells that's specific for just that antigen. Okay, now you've created, so that's your Navy, right? Against, I don't know, some country in the Middle East. because we're always fighting with them. A different antigen would be like the Marines going to Antarctica, just so there's no arguments. Because what's in Antarctica? Snow. Aliens. True story. All right. If there is a clone, and those clones are those bunches of T cells that react to ourselves, they're killed. All right, that's that process of thymic selection that we talked about when we first talked about the thymus. And so it said it takes an inventory of all your self proteins and then kills all those that react to yourself. That's what this is happening right here, the self-reactive process. All right. Once they are mature and have gone through this process, then they move to peripheral lymphoid organs like lymph nodes. All right, so once they're matured in the thymus, don't react to self-antigens, then they'll migrate out and go to lymphatic organs, other lymphatic organs. All right, this process of self-reactive takes place around the birthing process, just before and just after. All right, so that's why the thymus is so big in children, but then decreases as you get older because it's gone through this process. All right, so if we're talking about T cells, remind me, are we talking about the cell-mediated immunity or humoral-mediated immunity? Cell-mediated. So what are the types of T cells? Well, we have the Samaritans, the Good Samaritans. We have the helper T cells. All right. Their job is not to actually do anything against the antigen themselves, but they will stimulate the B cells to produce antibodies. It's like, anybody in here ever done competitive rowing? Nobody? You know, you have the boat and people are rowing, and then you have the coxswain in front that's yelling at everybody. Helper T cells are like the coxswain. Okay? So they stimulate the B cells and produce antibodies. All right? Typically, T helper cells are CD4 positive. All right? That is a protein on the surface of the cells that identifies them specifically as helper T cells. So this will go under the category of how do you tell the difference between the different types of T cells, the types of proteins that are on their surface. CD4 is what differentiates helper T cells. Memory T cells are formed as well. So when a T cell encounters an antigen, it will form memory cells that stay in lymphoid tissue, remain dormant, bless you, until you come in contact with that antigen again. So happens that CD4 is also the target for HIV. So they attack T helper cells specifically. Cytotoxic T cells are the other type. The name tells you exactly what they do. They're toxic to cells. So they will literally go and kill other cells. All right? They do so by inducing apoptosis. Do you remember what that is? Programmed cell death. Difference between apoptosis and necrosis. Apoptosis neatly packages a cell into death. Necrosis, you have lysozymes that are getting released and destroy surrounding tissue. You want a nice packaged death. All right, so cytotoxic T cells will do that to prevent further damage. Or they will poke holes in the membrane and, for all intents and purposes, perforate it. Or, deflate it. All right, cytotoxic T cells are CD8 positive. All right, so that's the protein that differentiates them. Okay. Helper T cells will release chemicals. Okay, these, what do we want to call them? Cytokines. One of them, interleukin-2, will come back to helper T cells and re-stimulate them. So this is one of those examples of autocrine secretion. So T helper cells can stimulate themselves. All right. They can also stimulate cytotoxic T cells using interleukin-2 as well as other cytokines. All right. So that means T helper cells will release cytokines that will help cytotoxic T cells do their job. By releasing IL-4, IL-5, IL-6, they will stimulate B cells. All right. They can also release cytokines to cause macrophages to bunch together, to activate macrophages, and to enhance macrophage killing. So what this tells you is that T helper cells are involved in all branches of the immune system. So if you knock out T helper cells, you've effectively killed your entire immune system, which is why HIV is such a dangerous disease, because it knocks out your entire immune system, both arms. All right, so let's specifically talk about the cellular branch, cellular-mediated branch. All right, cytotoxic T cells will attach to a foreign antigen-bearing cell. Let's do it a different color. It'll bind to the cell that's presenting an antigen. All right, that's how it recognizes it. It's all protein interactions. All right. It's going to release cytokines, all right, that are going to do a couple things. One, it's going to bring more cytotoxic T cells to that area, especially ones that are geared towards this antigen, and reactivate itself. Okay? And that's going to enhance the response to this particular antigen. All right? So that's what we see here. Here's our cytotoxic T cell. They've been activated, recruited to this area, and what they're going to do is they're going to attack this cell. Remember, induce apoptosis or poke holes in it, different mechanisms, cytotoxic or digestive enzymes. Specifically, what it's going to target are virus-infected cells, because virus-infected cells, remember, viruses will uncoat, they will get transcribed, they'll get repackaged, and then they'll be sent out of the cell. But some of their proteins will be displayed on the surface of the cell that's infected. That's what these cytotoxic T cells recognize, and they will kill the cell, therefore kill the virus. Does that make sense? All right, because if you kill the cell, the virus can't replicate. Do the same thing to cancer cells, because cancer cells are going to display proteins on their surface that are foreign, because the genome gets all messed up, so you're expressing proteins that are not normal proteins anymore. And cytotoxic T cells are also the mechanism by which organ rejection occurs with transplants. So when you have transplant rejection, just so you know, if you haven't heard this before, unless it's an organ coming from you or an identical twin, all transplants, I've never had twins in class before, so it's like a really good example. That's not true. I did have twins once. Before. All transplants will get rejected. Every transplant will get rejected at some point, unless it's coming from self. All right? It's just how long can we prolong that rejection? All transplants will always reject all the time. We haven't figured out a way around that yet. All right, so cellular-mediated immunity, it sounds real simple, but it's actually fairly complicated. We're not going to get into all the nitty-gritty details of it. Humoral immunity, all right? I want you to always associate humoral immunity with antibodies. All right? Cellular-mediated immunity, cytotoxic T cells, humoral-mediated immunity, antibodies, which by definition means you're dealing with B cells. All right? Although it's the B cells that are releasing antibodies that will do the job of the humoral immunity, it's helper T cells that are needed to activate these B cells. So again, the role of helper T cells involved in moderating this response. So we'll talk about how that's produced. At the end, what you produce from B cells that are activated are plasma cells. Plasma cells are just activated B cells. And memory cells. And they are against a specific antigen. Okay, that's the end product. We want antibodies produced by plasma cells against a specific antigen, and memory cells produced to lie in wait in case we're ever attacked by that again. All right, so how does it work? All right, first step, macrophages and B cells will both encounter antigens, the same antigen. Actually, they'll encounter a bunch of antigens, but they both have to encounter the same antigen for this to work. All right, where in our body are they both going to encounter the same antigen and be able to interact with each other? I know you know it. No? Lymph nodes. Did you? I didn't hear you. Speak loud.
I apologize too. I was like, I have no idea what you just said. I thought you were pointing at me. I was like, I don't know.
No. Speak loud. So I'll tell you guys, I may be somewhat loud in here, but I went to the bar with my wife last night and we left the kids at home. We got them at Wendy's, and we went to the Mexican restaurant, and we had sangria and a burrito. It was really good too. Cinco de Mayo in Rossford, really, really good. Oh, yeah, and of course, the restaurant's loud, and I'm sitting right next to my wife at the bar. Because we never get to sit at the bar because we have kids. And, she's kept after, because, I'm just not a loud talker. This is the only place where you see me be loud. That has nothing to do with this. All right. So, the point is, speak up, I can't hear you. Macrophages in a lymph node. So let's assume this is happening in an axillary lymph node. Okay. Macrophages will eat the foreign antigen. Somewhere in here, all of this is happening. going to explain it. Macrophages will eat the antigen. They'll digest it. Where is this occurring? Okay, here's macrophage digesting. All right, it's going to put the antigen on its surface within an MHC molecule. So what that means is, here's a macrophage. Here's the MHC, major histocompatibility complex. And the antigen will be displayed on its surface. So it's basically like holding up a flag saying, hey, I've got something. I've got something. Or it's like, you ever seen those movies where they say, all right, paint the target, and they have this laser, and they're putting it on the target so that the airplanes drop a bomb right on it. So this is like painting the target. Okay, so we have a macrophage that's ingested. It displays this on its surface, so that's what we see right here. Okay, it is then going to encounter a B cell and a T cell that's been exposed to the same antigen. And it makes sense that they're exposed to the same antigen because this is all happening within a lymph node. So they're in close proximity to each other. Okay, this is why you have these macrophages and lymph cells hanging out with each other in there. Mostly they're shooting the shit, but okay. The macrophage with the foreign particle will bind with the T cell, and again, this is going to be T helper cell, and activate that T helper cell. All right, notice they both can react to the same antigen because they've both been exposed. So these are all, at this point, clones. What I mean by clone is they recognize a specific antigen. Okay? To back up a little bit, all macrophages will display antigens on their surface within an MHC molecule. All right? T cells, T helper cells, there are different types of MHC molecules. All right? If this macrophage is displaying the antigen in an MHC class 1 molecule, you're going to be presenting to cytotoxic T cells. If you're presenting within an MHC class 2 molecule, you're presenting to T helper cells. So macrophages are going to put both on the surface, right? If there's a T helper cell nearby, it'll interact with this MHC class 2 with the antigen. If there's a cytotoxic T cell nearby, class 1. All right, so this is the molecular process of how things get activated. All right, so that T helper cell attaches to the foreign antigen on the macrophage, it gets activated. So if the macrophage eat, displays MHC with the antigen, T helper cell binds, becomes activated. All right. The T helper cell then will then detach, and it will find a B cell that's been exposed to the same antigen. So this is why you guys are like, what the fuck happened to that B cell? What happened to that B cell? Okay. The T helper cell will find a B cell that's been exposed to the same antigen, and it will release cytokines, that's these purples here, that will activate the B cell. Okay? It'll activate that B cell. All right, when it activates that B cell will then start dividing. All right, and this is what we call clonal expansion of that B cell. All right, when the B cell starts dividing, some of those B cells will become plasma cells. Where is that? Plasma cells. Some will become plasma cells. And what do plasma cells do? They secrete antibodies. Okay. Just a quick side trip right here. This is a B cell. These are different types of B cells that are residing in your lymph node. These right here are antibodies that are attached to the surface of the B cells. So it's actually an antibody that's attached to the surface of the B cell that's recognizing the foreign particle. Okay, it's a specific type of antibody. Okay, it's not IgM and it's not IgG. I think it's IgD, if I remember correctly. All right, so that's what these antibodies are. So when it binds the specific antigen right here, right, and it gets activated by a T helper cell, now you've created a bunch of clones of just this B cell expressing this antibody. Okay? And it's going to divide and expand. The plasma cells that get produced will take this antibody, repackage it into IgM or IgG, and that's what gets secreted. Okay? So, this specific antibody determines what kind of antibodies get secreted. If that doesn't make sense now, in a couple slides we'll talk about different types of antibodies, and hopefully that will make that make sense if it doesn't right now. Okay, so that's the process. But we're also going to, some of these B cells will become memory cells. All right? So what that means is that you're going to keep this specific one around as a memory cell so that when it gets comes in contact with this antigen ever again, you don't have to go through this activation process again. It's right there. It can just start dividing, producing antibodies. Okay? So this is a difference between our primary immune response and our secondary immune response, which we'll get into how that works. All right, some numbers. I don't care that you know these. We can produce up to 500 antigen-specific cells in 4 days, 500 antigen-specific progeny in 4 days, each producing 2,000 antibodies per second. What does that mean? It means we have a shitload of antibodies being secreted. All right, and this can persist for weeks at a time. So that's a lot. So when you are sick, one of the reasons why you don't have a lot of energy is because your immune system's spending a lot of energy producing a lot of these antibodies. And you're just like, oh. Oh, here it is. All right. So, primary versus secondary responses. If we get exposed to an antigen, it takes time to build up an immune response, right? So nothing's happening. And then we get their immune response, and the peak immune response happens at about 20 days. So about 2.5 weeks. So that's why when you go to the doctor and he says, you got a virus, how long's it been going on? About a week. All right, we're not going to do anything because your peak immune response is not going to happen for about another week, week and a half. You'll start feeling better. Okay? And then it dies down as you've gotten rid of the antigen, okay, or the foreign invader. But during this process, you've produced memory cells. And those memory cells are going to lie in wait, right? So that if you are exposed to the antigen a second time, notice what happens. Let's say this is 20, 30. 55 days, you've produced an immune response much larger and much stronger than your secondary in half the amount of time because you have those memory cells. I think we have another graph later on that shows this a little bit better. Okay, so primary immune response, not as many antibodies, takes a long time to occur, not as strong. Secondary immune response, because you have memory cells to that specific antigen, shorter time for it to get activated, much stronger response, and much more effective. All right, so what are antibodies? All right, antibodies have this very specific structure, this Y shape right here, and you have two ends. All right, antibodies are also called immunoglobulins, Ig, which is where we get IgG from. All right, two ends. We have our antigen binding end, all right, or end that has the antigen binding sites. And then we have our constant region. All right, the antigen binding region and our constant region. All right, the antigen binding region is specific for binding foreign particles. All right, when we talked about that cell that's displaying the antibody on its surface, it's displaying the antigen binding regions. So it can bind the antigen. All right, this region, the constant region, also called the effector region or the effector end, all right, determines what the antibody does. All right, so you bind the antigen, now what are you going to do with it? All right, if it's this kind of antibody right here, this is going to cause the help with the activation and clonal selection of the B cell. Okay, if it's another type, it'll do different things. So here's the different types that you should be familiar with. The biggest ones you should be familiar with, Igm and Igg. All right, this is the structure of Igm right here. All right, you're like, that doesn't look like an antibody at all. Well, here's a Y, here's a Y, here's a Y. So it's what we call a pentamer of antibodies. And this is what's released during our primary immune response. All right, Igm is what's released. Okay. What it does is it activates complement. We'll talk about what complement is in a few minutes. No, I'm not going to have you know the entire complement cascade and how what factor gets converted to what. Have you guys ever done that before? It's a pain in the ass. Not relevant for us, I don't think. But you should know what complement is. IgG. IgG is our most abundant antibody. And the one, when we think of antibodies, this is the one we think of. All right? 75% of all immunoglobulins found in tissue. It will also bind antigen, and it will activate complement, amongst other things. IgA, specific antibody found in tears, exocrine secretions. All right, so one of our defense mechanisms. IgD is the one I was talking about right here. The one that's displayed on the surface of B cells that's involved in B cell activation and clonal selection. All right, so IgD serves that purpose alone. And then IgE, I'm not an immunologist, and I actually would like to know the answer to this question. We know it is involved in allergic reactions. But what's it supposed to do? Because allergic reactions are not something that's a disorder, right? So what is it actually supposed to do? I'm not 100% sure, simply because I'm not up on the literature. All right, but do know that it's involved in allergic reactions. And in fact, the reason why you have allergic reactions is because you produce IgE as a response instead of IgG. Right? So for some reason you start producing IgE molecules instead of IgG, and that's what gives you the allergies. All right. This is important for your test on Wednesday. I know, I said I'm not putting this on there, but this relates back to what we've talked about before. And if you think about it, you'll see why. Immunoglobulins make up about 20% of plasma proteins. Okay, we talked about plasma proteins. And where do immunoglobulins, where do they come from? Pardon? Plasma cells, which come from B cells, which come from location? Bone marrow. Remember that. That's going to help you with your test on Wednesday, I promise. All right, so what's the complement system? Basically, it's a bunch of proteins that are circulating already through our body. And when we have an antigen-antibody complex, like in the case of IgM, which activates complement, that's going to activate these proteins and start this cascade that looks very similar to a clotting cascade, whose job it will be to either make bacteria more attractive to macrophages. That's what opsonization is. Make bacteria more attractive to macrophages. In other words, it's like sprinkling the sugar on it to make macrophages go, ooh, I want to eat that. Complement will also activate mast cells and basophils, helping with the inflammatory response. And complement will cause the chemotaxis of white blood cells. In other words, make a chemical gradient for white blood cells to come to an area of infection. All right. The last thing it'll do is it'll make something called a membrane attack complex. All right. If you want to kill a cell that's that's foreign, you attack its membrane and bust it open. So complement is involved in doing that, and will help lyse cells. Again, antibodies, what are they doing? Binding. It's all this other stuff that's doing the work, okay? Antibodies just direct the response. Okay, going to immune responses, back to primary versus secondary. I like this graph better because it has two separate time courses to it. Primary immune response, peak response, about between 20 and 30 days, right? About 2 to 3 weeks. Secondary immune response, peak response, about 10 days, right? And so not only is it quicker by about a third, 2/3 actually, but it's much stronger as well. Okay, so this just shows you specifically the difference in time course. Would you rather have something operating at 25 days or something operating at 12 days? So I guess that's half the response, half the time. All right, and what drives secondary immune responses specifically? What type of memory cells? Good. All right, this is where things get a little more interesting, I guess, and more practically applicable to you. Different types of immunity. So these are the categories right here. Naturally acquired active immunity. Naturally means it's going to naturally happen in your everyday activities. All right? Active immunity means you are actively activating T cells and B cells. Mostly B cells. This is mostly humoral. All right? So the example of this is exposure to live pathogens. COVID. You're exposed to COVID. You get immune to COVID. Naturally acquired active immunity. Naturally acquired passive immunity is where you are getting antibodies from an exogenous source. So you were born with a immunodeficiency disease. You have to go every year to get antibodies injected into you. That's naturally... Nope. She's laughing at me because she knew I screwed it up before I even noticed it. Okay, we'll do the example that's up there. When babies are born and you actually breastfeed, antibodies are passed from the mother to the fetus. All right, that's a natural source, and they're getting immunity. Why it's passive is because they're not producing the immune response themselves. Okay, so are they ever going to produce memory cells? No, they're relying on somebody else's immunity to protect them. Artificially acquired active immunity, you have an artificial means of activating the immune system. This is what vaccinations are all about. Artificially acquired active immunity. I'm going to take an epitope from a pathogen, inject it into you, have you form antibodies against that antigen, that pathogen, so that if you ever actually encounter the pathogen, you have a secondary immune response. And then artificially acquired passive immunity. Your dumbass decides to go walking in Brazilian rainforest with shorts on, and a snake bites you. And you're like, oh, I need help. And you go to the doctor and they give you antibodies against that venom. So they injected something into you that's artificial, and you didn't produce memory responses to that pathogen or that antigen. Passive immunity. Okay, so make sure you know the difference between those and be able to provide examples of it. I tell you to provide examples of it, but you're taking a multiple choice test. Be familiar with examples. All right, so that brings us to immunization. Basically, we either take... Let's say this is a protein from a virus, and we take that part of the protein, inject it into your body, and you form antibodies against that part of the protein. So if you're ever exposed to, let's say, the pathogen that causes diphtheria, you already have memory cells that will produce antibodies against diphtheria, and you don't get sick from it. Okay? Or we could inject dead diphtheria bacteria into your body, which won't cause a disease, but will cause you to form an antigen response, or an antibody response. Okay? Or we could say, hey, we're going to manipulate this pathogen so it's not going to make you sick. We're going to inject it into your body, so if you ever come in contact with the pathogen that will make you sick, you can defend against it. So different types of immunizations all geared towards the same thing. Making memory cells so that if you're actually exposed to any of these things, you produce an immune response against it. The newest thing that we're all familiar with by this point is injecting mRNA into your body, forcing your own cells to produce viral epitopes so that you form an immune response so that if you get exposed to COVID, you don't get sick from it. Okay? That's the theory behind it. We're not getting into how well it works, why it works that well, or not that well. Why it works in some people, why it doesn't. Because there's a whole level of political misunderstanding that's driving a lot of decisions that are being made. And I'm not getting into it. All right. These last few slides are kind of disease related. So a couple terms that you'll come across in your practice: immunologic competence versus immunodeficiency. So if we're immunocompetent, that means we are able to effectively mount an immune response against the pathogen. So unless one of you in here has an immunodeficiency disease, we are all considered immunocompetent. Okay? If one or more parts of our immune system, like let's say we get HIV infection and develop AIDS, AIDS is acquired immunodeficiency syndrome. Okay? It's not autoimmune deficiency syndrome. It's acquired immune deficiency syndrome. People mix that up all the time. Those are two very different diseases. You don't have your T helper cells anymore. If you don't have your T helper cells, you can't activate cytotoxic cells. You can't activate B cells. You have no immune system. You're not immunocompetent. You have an immunodeficiency. All right, immunological tolerance, the host, meaning you, exposed to things, have destructive mechanisms against pathogens. Finish? Yeah? Okay. Tolerance specifically is associated with the specific immune system, so immunity. And we do it through all right, let's explain this really simply and then move on to the next slide. This is our ability to distinguish self from non-self, immune tolerance. All right. If we don't have immune tolerance and we can't distinguish self from non-self, that's when we get into autoimmunity. Okay? So autoimmunity is where our own antibodies are attacking tissues within our body. Some examples of that: post-streptococcal glomerulonephritis. This is a really good example. What happens with this? Actually, that's a shitty example. It's a bad example because it doesn't get across the point that I want to get across. Myasthenia gravis is. All right, myasthenia gravis is you form antibodies against acetylcholine receptors. All right, where are acetylcholine receptors primarily? We have a test on this on Wednesday. Begins with N, rhymes with neuromuscular junction. The neuromuscular junction, right? If you have antibodies against acetylcholine receptors, or two acetylcholine receptors, they actually will alter the way those acetylcholine receptors work. Okay? Producing the disease effects. Lupus, you have antibodies against multiple things, and it's a systemic disease. All right? So basically, immune response against and I'm not holding you responsible for any mechanisms. These are just examples. Immune responses against your own body. Okay, that's what autoimmunity is. And definitely know the difference between an autoimmune disease and an immunodeficiency. They're two very different things. All right, allergic reactions are stupid. They suck. It's an immune attack against something that's not harmful to you. I love peanuts. If I ever developed an allergy to peanuts, I would be super sad. Is anybody in here allergic to peanuts? No? Sweet. So, we have a big response in our body against something that's not harmful. Okay? For a number of different reasons. The biggest reason is that we produce IgE antibodies against this instead of IgG. So a lot of therapies are actually geared towards, if they can get rid of the allergy, they're geared towards converting the IgE response into an IgG response. And if you have an IgG response, no allergy. Okay? All right. Allergies are type 1 hypersensitivity. There are other types of hypersensitivities. Some that take a little bit longer than allergies. Type 2, those are cytotoxic. That's what happens during a transfusion reaction. So you put type B blood into type A blood, and you get that agglutination, and antibodies come and destroy. This is what happens. Type 3 is a immune complex reaction. Basically, what happens with this is at post-streptococcal glomerulonephritis, where you form immune complexes and they travel in the bloodstream and block blood vessels. If that happens in the kidneys, in the glomeruli, and you can't filter, that affects your ability to clean your blood. And then finally, type 4 is our delayed type hypersensitivity. The biggest example of that, poison ivy, is a delayed type hypersensitivity. You could be walking in the woods, so this happened to me. I was living in Illinois, doing my postdoc, and my wife came to visit me before she was my wife. And we were walking through the woods. It was a nice day in the middle of winter. It was like one of those rare 70-degree days. So we went walking on paths. And we go off the beaten path. Like, we just like to explore. 2 days later, I had rashes all up my arm because that oil from poison ivy stays on the branches even if the leaves aren't there. So, again, I didn't know it until 2 days later. And then it spreads. Why does it spread? Not because you scratch it, but because my clothes had it on there too. My shoes. I tie my shoes, I touch my arm, it spreads. Sucks. So, that's a delayed type. Latex allergies, also delayed type hypersensitivity. All right, last interesting factoid. And this is something, if you're interested in reading more about this, there's a book called The Angel and the Assassin. And that describes a lot of what this is.